Thank you, Weber sir, for this kind opportunity, and good morning, everyone. As Dr. Londe sir just pointed out, that it really worries us sometimes, the pins that we place when we are doing the robotics. Are we going to have an infection? Is it going to end up in a fracture? So I hope that in coming years from now, there will be no requirement for this talk at all, and we'll move completely towards pinless at some stage. So right now I'm using these two robots at two different hospitals. And what is the importance of the pin fixation? Why even talk about it? Because even a micro motion of the pin that happens intraoperatively, if you lose even slightest of the fixation of the pin, you're going to lose the game. So the robotic is not going to work if it detects any excessive pin movement. Secondly, if you have not positioned your pin properly, you're going to struggle all throughout your case because, as Sir said, that sometimes the array will not be visible. And the most common reason would be the angle, the position of your pins, and how you have placed your arrays. If you place your pins too distal or too much towards the joint, sometimes when you're taking your cut with the saw or the burr, and when you're trialing your implant, especially the femur, your pin may come in the way. So it is very important that over a period of time with practice and going right the first time, you want to place your pins properly. So ideally, this is what most of the robotic manuals will describe, that this is how your pins should be placed, around 30 to 50 degree angulation. We are talking about the femur on the medial side. Most surgeons will find tibia pin to be a little bit more easy because we are all used to doing the external fixators from our residency days. So tibial pins are a bit easy. It is a femur which can be a little bit of a challenge. So safe zones, if you are less than 45 degree, it means if you are going more anterior to posterior, there are higher chances of complication happening, especially in women. Neurovascular deficits have been reported with pin placement. So please be very wary if you're putting your plane, if it is perpendicular or AP. You want to be more mediolateral. So, with regards to the pin diameters, there were some old studies which suggested that smaller diameter pins will have lesser complications. But this is a very good paper which I found, which says that whether it is 3.5 or 4.5, there's not statistically different rate in terms of fracture or in terms of complications happening. So this is what is a recommended pin method. So if you see carefully over here, the pin has not penetrated completely the far cortex. And this is a very, very important point. And this is where your feel comes during the surgery. That you do not want to have that second giveaway completely. You don't want your pin protruding from the second cortex. Because this is going to be the biggest stress riser. And if you're avoiding this, just about to when you're about to perforate and go across the second cortex, you want to stop over there. You will get the purchase, but you would not have penetrated the second cortex. So this is the most important take-home message for the pin placement. So usually most of the fractures would happen because of suboptimal placement of the tracker pins, and femur is where the most commonly the fractures have been noted in the literature. It has been seen that at least you have had transcortical fixation of one of the pins, and that is the most important reason why people have ended up with a fracture. Where do you place your pins? There were surgeons in the past who would place all four pins outside the incision. Then many of them moved to femur within, and for me, I put all my pins inside the incision. Now, some surgeons would not like it because the patient would question if you really used a robotic, if you don't see those two separate stab incisions. But I think there is lesser worry in terms of whether that pin tractor is going to get infected for me. So I place all my pins within the incision. One trick for those people who still want to use the tibial pins outside the incision, please take a very good and long stab incision. Don't be stingy at that, because if you have a very small skin incision, the rotation of the pin when you are putting it onto the bone, that is what the drill, that is what is going to cause thermal necrosis and not allowing your wound to heal or even get infected. So even if you want to use your pin outside the incision, please take a nice big stab incision so that there is no pressure on the margin. So intra-incisional pin placement, that's what I'm talking about, has found to be very, very safe and lesser chances of infection happening. So in short, with regards to the pin, if I would summarize the pin thing, if you were to put the pins, we all know we put it perpendicular to the bone surface. But if you were to err it, you don't want to put your pins directed away from the joint. As we are getting our pins closer to the knee joint, we want the away part of the pins to be away and the near part of the pins to be nearer to the knee joint. So the direction of the pins has to be perpendicular, but if you're erring on one side, if you're putting it in a particular way, please make sure that your pins are pointing towards the knee joint and not away from it. So that's one important thing. So arrays, there should be a clear line of sight. Yes, we have got very good arrays. Some of our arrays last for even 80 or 100 cases in some of the systems. The surgeon access to the knee joint should not be compromised. So please make sure that you're not putting the arrays very close to the skin. At least nice two finger breadths should be away from the skin, and that's where you want to put your arrays. It should be visible both during flexion as well as extension, and the saw axis should not also be impacted. Coming quickly to the registration, yes, we did talk about image versus imageless registration, and image-based systems will help you to confirm that what you're registering is matching with the pre-op plan or not. The counter argument to the imageless guys is the image system may not differentiate nicely between a bone and an osteophyte. So you're also registering your osteophytes, which I'm not very comfortable about. So probably an imageless system will help me take away all those osteophytes when you're entering the joint and then register what actually you want to register. So yes, registration helps because it helps us understand the native hip knee axis. We can register the pre and post-op range of motion, and we can identify the gaps before and after the balancing. So why do we require the registration? Because we want to assess the joint, we want to plan our implant position, our balance, our alignment, and to execute the plan accurately. Now, sometimes you may have some varied anatomy. Sometimes there might be defects, you might have osteophytes, and you will need to know that what you want to register. Because what you register is going to give you the plan. Unfortunately, as of now, we do not have that AI where the robot itself is deciding that, okay, this is the point I want to consider, this I can ignore. Whatever data you give into the robot is going to decide what plan you get at the end of it. So it is very important that you identify the correct landmarks. So every system, I believe, has got these checkpoints. So there is one femur checkpoint and there is one tibia checkpoint. Either it can be a small anatomical landmark over the bone, or it could be over your pins, or you can have a metal checkpoint which the system recommends that you put these checkpoints in the femur as well as in the tibia. And before cutting, every time the system asks you to go to that checkpoint to make sure that those checkpoints have not moved in relation to the pins. So each of us have devised our own method where we are using some checkpoints on our base of the arrays. But remember that all robotic systems have got these checkpoints which make sure that your pins have not moved and your trackers are in the position where they should be. So one common error with many systems is that the base of the arrays have got teeth like this, and sometimes in a hurry you might not match this correctly. And towards the middle of the case, sometimes this will suddenly match, but your arrays would have moved. So please remember that whichever system you use, you got to match the sawtooth very correctly. Acquisition, with more and more newer generation robots coming in, the acquisition is becoming simpler and faster. Some of the systems will have a lot of registration points, maybe 60, 70, 80 registration points, and you have to paint the entire surface. But the newer systems coming in have got lesser registration points, only the most important ones, where you're talking about the lowermost part of the medial plateau or the highest part of the lateral plateau. You're registering the tibial tubercle. And with the femur, you're going on the epicondyle, transepicondylar axis, the white sides line. Again, when it comes to the distal femur condyle, you're talking about the most distal part. When you're talking about the posterior femur condyle, we are talking about the most posterior part. There are always some tips and tricks with every system. You don't want to hyperflex the knee because you may be way past the posterior most point. You don't want to underflex the knee because you may not reach the posterior point. So get in a way of handling your system so that you know which points to register and which are the tips and tricks with each system. Very important thing is this anterior cortex acquisition. You don't want to end up with a case where you're notching the femur, especially when it is the robot cutting the bone. So as Vaibhav sir correctly says that you always want to have 3 checkpoints, maybe 2 with the robot, 1 with the man, where you can keep the saw blade at the side of the femur, or you can actually see at the side of the femur where the robot is actually going to cut. So before you do that, you want to always double check where the anterior cortex registration has been done. And this is one very important thing with every system that you do. So you confirm your landmarks, whether they are in the acceptable range or not. If it is more than 1 millimeter away, any system is going to ask you to re-register. So to summarize the registration part of it, please make sure that with any system, your array is not in the air and it is touching the bone, because any point which is in the air, the robot is not going to know about it. So robot might register it as, the robot might consider it as a bony point. So please make sure that whenever you're registering, the array is always touching the bone. It should be a smooth, continuous capture. Please identify the true bony landmarks, and sometimes some osteophyte or some depressions you may have to ignore, because if that is the lowest point considered, the robot may suggest you to cut from beneath it. And always verify and confirm your 3D plan. Thank you.